And the next lecture is a lecture from Portugal, a lecture of Professor Fіломена Рібейро. She is the next president of the ESCRS and professor of clinic in Portugal. Okay, Filomena, your turn.
Thank you for the invitation to be here. It really is a great pleasure. Right now, we are facing an increasing number of patients that need cataract surgery after corneal refractive surgery. This population presents unique challenge to the cataract surgeon due to the high expectations for visual outcomes and spectacle independence, and also the difficulty of intraocular lens power estimation. In these patients, the main cause for refractive error in IOL prediction lies in the difficulty to measure the real corneal power after refractive surgery. And we also know that very frequently in these cases there are associated dry eye disease with greater variability in the K measurements, with difference that can reach more than 1 diopter. This has been studied, and now we know that if we treat dry eye before the measurements, we can increase the number of cases below half of diopter or sphere and also less residual astigmatism. Other issues in measuring the cornea are the change relationship between the posterior and anterior corneal surface, which makes the keratometric index not valid in these cases. A second problem is that the corneal curvature radius is measured out of the optical zone at different distance for steep and more curved corneas. Also, the ELP estimation is in many formulas related with the dioptric power of the cornea, which has been changed and is also a source of error for IOL power calculation. After myopic corneal ablations, we have a low posterior-anterior ratio. We can measure a steeper corneal curvature than in the central area. That's why several authors have suggested using the central values provided by corneal topography rather than the simulated keratometry to calculate the corneal power after excimer laser surgery. And we also have a more anterior ELP estimation. All these factors together can drive to a hyperopic refractive error after the cataract surgery. And precisely the opposite will happen in case of post-hyperopic LASIK, leading to a myopic residual error. And of course, all these issues are clinical more relevant in cases of small or the center treatments, where the corneal radius can be measured on the periphery of the treat zone and be different with respect to that passing through the visual axis. Also, we have to take into account the change in spherical aberration and all high-order aberrations, and the fact that usually these corneas are multifocal corneas. In summary, these are the problems that we had to solve along this last decade. More than 30 methods to calculate IOL power in these eyes over the last 15 years were developed. Such a large number of methods can improve the chance of achieving the desired outcome, but can also generate some confusion among the surgeons who do not know which is the best method for their patients. A practical solution is the ESCRS online calculator. This calculator allows us to input data from different devices and provides a multi-formula calculation with regular actualization. In alternative, and to reduce the potential for transcription error from manual data entry, we can choose to use new formulas already set in our biometers, like this one. Several papers have compared some of these methods and with very good results. The Barrett True K formula with TK measurements from IOL Master 700 has shown to perform as well as the multiple form approach of the ESCRS online calculator in both post-myopic and post-hyperopic eyes. So TK can improve, but using TK in other existing post-LASIK formulas did not seem to improve because these formulas need to be optimized for use of TK values. EVO formula is one of the formulas that already has this possibility to input TK values, but no results published so far. Several papers have compared different formulas. This is a meta-analysis published in 2020 showing that our probability of success to achieve results within half of diopter is around 60% of the cases, with great hope in OCT corneal measurements. Intraoperative aberrometry is another promising option in patients with a history of refractive surgery. Recent studies have found this method to be able to reach target refraction in almost similar percentage to virgin eyes, although this technique also has its limitations, as aphakic measurements must be taken in the operating room with variability related with intraocular pressure, patient fixation, and sternal pressure from the speculum. In addition, determining the effective lens position with this method still remains a source of error. So, IOL power calculation after corneal refractive surgery can be calculated with a variety of methods that lead to relative accurate outcomes, with 60 to 70% of the eyes showing a prediction error within half of diopter. But we still have a lot of improvement, like the Pearl formula that I show here in this slide. And these are the results presented by the authors of this formula in a ESCRS Congress with better performance than the other formulas compared. And what about toric calculation? We know, following this paper from Cow, that toric IOLs can be effective in eyes with previous laser corneal refractive surgery, even in post-RK cases. Of course, we need to follow some criteria, and we only treat regular astigmatism in the 3 millimeters of the center of the cornea, and we should check for difference between different measurements in value and also in axis. Because these patients have a mindset of achieving as much freedom from glasses as possible, this means that they are often interested in presbyopia correcting IOLs. Some studies have shown good results in select cases with multifocal IOLs, but in these cases we should explain to these patients that they can need an enhancement in the post-op period in order to achieve the planar results that is required for the best results from a multifocal IOL. We also have published very good results with also a diffractive IOL, but a different optical concept, a need of IOL. And with these IOLs, we also can benefit from more residual error tolerance. But right now we have several other options. We have enhanced monofocal IOLs and new refractive EDOF concepts. These IOLs, they play with different spherical aberration, and then they can also provide a very good alternative in these cases, with the possibility of matching the change in the cornea by the previous laser treatment, since, for example, the IANS and VVT IOL, they have an increase of negative spherical aberration, and in the opposite, Ray 1 EMV with an increase of positive spherical aberration. So we can have a match to the spherical aberration of these corneas. Right now, we also have new add-on concept of IOLs. They allowed us new possibilities of treatment, including in duet in cataract surgery, for cases with biometric or pathological doubts, or even for these cases of very irregular cornea, with the add-on sternobate IOLs that provide a very good depth of field because they are a pure concept of EDOF IOLs. So in conclusion, right now, we have a better understanding of dioptric power measurements in case of cataract after corneorefractive surgery. We also have new formulas with the correction of all causes of error that provide a very successful IOL power calculation in these cases. We also are fortunate to have toric and PC IOL solutions, but nevertheless, we always need to discuss with our patients potential refractive errors and expectations after cataract surgery. Thank you so much.
Thank you, dear Professor Філомена Рібейро. Sure, we face with these patients more and more frequent, and your lecture will be a very great support for us to management of this patient,